The first half we talked about what is this thing we're dealing with and what are the common symptoms. When I'm experiencing a symptom, is that a common symptom of Parkinson's or not? And the second part we're going to talk about now is, all right, well now we know what it is, what are we going to do about it? So we're going to talk about some of the treatments. For some people in the room, this may be stuff you're very familiar with, and for some people in the room, it may be a preview of what are my options. We'll talk mostly about medicines, but also non-medicine therapies and just a little bit about surgery. When we get to the question part, I will be happy to take questions about medicines or other treatments. Please be aware that only your own doctor who examines you and knows all of your health conditions and knows what you've tried in the past can really give you personal advice about the best medicine for you. But I am happy to answer sort of more generic questions about medications. Okay, so first question is, when do you treat and what do you treat? So true or false, the goal is to wait as long as you possibly can to take medication. Okay, what a bright room. But even though I heard a lot of false, many people secretly have this idea that I have to try really hard not to take medicine and really hard not to raise medicine. We certainly don't want to raise medicine or take it when we don't need it or use more than we need, but we also don't want to deny ourselves treatment in a way that compromises how active we can be and what our quality of life is. So the answer is we have to think about both today and the future and not take too much or too little, but find the right balance. So as a preview, these are many medicines for Parkinson's, and we'll go over them kind of one at a time and just highlight a few points. And then again, specific questions. We have a great chunk of time for that. I'll probably finish a little ahead of time so we have extra time for questions. So probably the oldest class of medicines are these called anticholinergics, and they actually work on acetylcholine, not even dopamine, and indirectly help dopamine function. There's another medicine called amantadine. It was invented to be a flu medicine, and it just incidentally got discovered that it was a Parkinson medicine. It doesn't help with today's flu, but at the time it was a flu medicine. We'll talk about monoamine oxidase type B inhibitors and catechol O-methyltransferase inhibitors. I'll go through these one at a time, but these two groups of medicine help slow down the way dopamine gets chewed up, the way it gets metabolized so that it hangs out longer to be active. Dopamine agonists are medicines that stimulate dopamine receptors, and levodopa gets turned into dopamine. So we'll go through these one at a time. This is just a picture. Don't worry if you can't see it. Don't worry if it looks meaningless. But what it's a picture of is a dopamine nerve terminal and the receptors where it binds and where the medicines work. Dopamine receptors, dopamine agonists stimulate those dopamine receptors. Levodopa gets converted into dopamine so that it can act on dopamine receptors. And some of the medicines affect the way that dopamine gets broken down so that it can be longer available and more active. So with so many choices, how do we know where to start? Well, we look at age of the person. We look at what are the goals of treatment. Is it walking that bothers you? Is it tremor that bothers you? Is it depression that bothers you? What are the comorbidities? What else is going on? What other health conditions and symptoms are going on in that person? How bad are their symptoms? What's the severity of the disease? And what is the cost of the medicine? I don't even have to ask for a show of hands if there's been anybody that the cost of medicine was a challenge to taking what you or your doctor thought you should be on. It's a big issue. So just as an example, a 52-year-old man comes because of some right hand tremor, very small amount of tremor, a little change in the handwriting, and feeling a little stiff in the shoulder. So do you need medicine? Do you not need medicine? And what would you do? Well, it depends on the person. For some people, a little bit of tremor is not a big deal. For someone who's a lawyer or an executive, maybe having tremor is undesirable. So it depends on how much it affects each person. And what's a severe tremor for me might be different than for Pete or someone else. If this tremor bothers the person and the symptoms are affecting quality of life, we might try medication. Just say before I say anything else, and don't even worry if you can't see the words from the back of the room because I'm going to tell you everything The words are just there for reference, and they're going to be posted as I understand. But what I want to say is when I talk about medicines right now, and I discuss one person with early Parkinson's and one who's had it a little bit longer, by no means are there rules that certain medicines are only for early Parkinson's or only for severe Parkinson's. They're all options at every stage of Parkinson's. But I'm just going to discuss them in a sequence and use some examples that make it look like some are more for early and some are more for advanced. One of the medicines is named amantadine. Amantadine is the one that was invented to be a flu medicine, and incidentally, people with Parkinson's or tremors had improvement, and now we use it only as a Parkinson or tremor medicine. This medicine is interesting because it doesn't work on dopamine the same way as the others, but it's sort of an incidental impact on dopamine transmission. It can be helpful especially for tremors, and it can be helpful for fatigue. But unfortunately, some people can have problems with hallucinations or cloudy thinking. There's a rare kind of skin condition called levodopa, which is sort of a lacy skin rash that could be a side effect, but it's very rare. And because it kind of can give energy, we try to avoid taking it very late at night because it could affect people's sleep. It also can be helpful when people have had Parkinson's for a while because it can help with the dyskinesias, the involuntary movements. It can suppress dyskinesias. Another class of medication called the anticholinergics involves a medicine called trihexyphenidyl or Artane and benztropine or cogentin. These are not used as much because the symptomatic benefit is more mild and the side effects can be limiting. They can cause dry mouth, urinary retention where you can't urinate when you want to, balance troubles and confusion, and hallucinations. So we have to be very careful with those medicines. But those two are commonly used either in early Parkinson's or amantadine later on when people have dyskinesia. Another class of medicines called the monoamine oxidase B inhibitors or MAOB inhibitors includes selegiline and rasagiline or Azilect. These medicines also have a milder potency compared to some other medicines, but can be helpful either with mild symptoms or to bridge when people have wearing off. Sometimes adding them can help the medicine last longer. There are some issues that these medicines interact with lots of other medicines. So if you're on one of these, every time you want to take something, even over the counter, you need to ask the pharmacist to check that it doesn't interact with your medicines or ask your physician. There are also some interesting things that when people take these medicines, they're told that they can't eat certain foods that contain something called tyramine. And those foods include things like aged cheeses and sausages and wines. The truth is, eating those foods is probably very safe with these medications. There are older medicines that were not only type B inhibitors, but they inhibited all the MAO enzymes, one of which metabolizes tyramine. So most people take these medicines, can eat whatever they want, but they do have a milder symptomatic effect. Some question that commonly comes up is, do these medicines slow down Parkinson's? And that's based on the fact that compounds similar to these have been able to do useful things to cells in a culture or animals that have insults done to them that might have similarities to Parkinson's. So it was thought that maybe these could be useful in humans to slow down Parkinson's. And in big studies that have been done, the differences in people who took them earlier compared to people who had a delay till they got them were very, very subtle. So most people believe it's mostly a symptomatic benefit rather than really changing the course of Parkinson's, but that's one of the things that comes up. So let's talk, those are just a few of the medicines. Now what if somebody is a woman who had Parkinson's for 4 years? She takes selegiline only. She starts having cramping in her legs and her husband thinks she's starting to shuffle. She's having a harder time keeping up with her dance group that she goes to, and she's sitting out more of the dances. Well, at this point, to me, she's sacrificing her normal activities, her healthy activities, and her quality of life is affected. So it looks like one medicine is not doing enough. And this medicine really only has one dose. It's either helping or it's not helping. So at that point, we might say, well, what else do you have besides those first 3 that you told us about? And I'm going to talk about these medicines called dopamine agonists, but it's not that you can't start with those medicines. They can be an option as a first medicine or a third medicine, but in this case I'm just discussing a lady who was on just one and it was her second medicine. There are 3 main medicines, actually 4 in this class. These medicines mimic dopamine, so they stimulate dopamine receptors like your own dopamine, but they're not dopamine. The names are pramipexole or Mirapex, which comes in a slow release or an extended release and a regular formulation. Ropinirole or Requip, which also has a short-acting and a long-acting form. And rotigotine or Nupro, which is a patch. Those 3 medications have a similar efficacy, but they're just different. You can try one and some people do better with one or the other. The important things about the patch in particular are it is a 24-hour system, so you put it on once a day and it lasts 24 hours. You have to hold your hand over it when you put it on for 30 seconds to make it stick, and you have to rotate where you put it. You don't put it the same spot every single day. You could get a rash. You have to move it. You can go from your arm to your belly to your back to your thighs to your arm. And so those medications, I'm going to tell you about some interesting side effects that could occur. But I want to just mention a medicine that very few people will ever take in this room called apomorphine or Apokyn. It's actually an injectable dopamine agonist that we save for people who have very sudden, momentary wearing off. So they could be fine and their medicine wears off all of a sudden and they are kind of stuck. And they would inject this as what we call a rescue medicine. It's rarely used because it has to be injected. And also there are some side effects that could be sudden drop of blood pressure or nausea. So that medicine can only be given for the first time in a doctor's office and has to have special monitoring the first time it's used, and it's rarely used in normal practice. Just wanted to have mentioned it. If anybody has heard of pergolide or bromocriptine, they used to be medicines of this class that would cause heart valve problems, so they kind of went off the market. So these medicines are active and helpful, but they could cause side effects that could include sleepiness or even sleep attacks, falling asleep all of a sudden in the middle of things. So if we were to start one of these medicines, we wouldn't advise a long drive the next day. You'd want to make sure you tolerate them well before you did something like that. They could cause swelling of the legs, nausea, lowering of blood pressure, hallucinations, and most interestingly, certain compulsive or impulsive behaviors. What do I mean by that? Well, dopamine is important in the reward systems of the brain. People who are addicted to drugs, it stimulates dopamine release. Happy things stimulate dopamine release. Well, these medicines do pulsatile stimulation, so they're stimulating those receptors in a way that's different than the usual when you don't have Parkinson's, where it's sort of steady all the time. It's coming in punches. And what can happen are people can get sudden urges to do things like gamble or spend money impulsively in a way that's not in proportion with their normal financial budget. People could have hypersexuality, which isn't a good thing. When people hear that, they always go, oh, that sounds not so bad. It's actually an unpleasant drive or preoccupying thoughts. Some people could suddenly have urges to do things or look at things that they didn't typically do, and it can be disruptive. If you don't know that these can occur, you wouldn't think to tell your neurologist necessarily about them. When they occur because of medicine, if the medicine is lowered or stopped, they go away. So they shouldn't make a person afraid to take the medicine because they're totally reversible the majority of the time, but you have to know they exist. So these could include things like suddenly wanting to do a lot of scratch-off lotto tickets, buying things, bidding on eBay, or even compulsively doing hobbies like painting or crafting or quilting or fishing. I've seen all of those. So they can show up in lots of different ways. So it's sort of having a lot of drive to do something different from what's normal for the person. They're not necessarily common, but they're not rare either. So if you experience those, you definitely want to talk with your healthcare provider about them. Okay, so what if you took one of these medicines and you liked it, it helped you, but you developed something like that? You started swelling or sick to your stomach. It usually gets better when you stop the medicine. It is important that these medicines are weaned and not stopped all of a sudden. Just like you go onto it gradually, you need to come off of it gradually unless there's a life-threatening side effect, which would be unlikely. because people could develop withdrawal symptoms where they feel sick to their stomach or anxious or have symptoms that can be side effects of stopping too quickly. All the medicines for Parkinson's shouldn't necessarily be stopped suddenly. Selagiline, amantadine, the milder ones, people can get away with stopping suddenly. But Sinemet and all these dopamine agonists need to be weaned because people could have a rebound of symptoms and get very stiff. They could have high blood pressure. They could have bad side effects if the medicine is stopped abruptly. The biggest time that's a problem is when people go in the hospital and they don't have control of their medicines, and I think probably we'll hear maybe about that after a while. We hear about hospitalization, not today? Okay. Well, anyway, the National Parkinson Foundation has done a big campaign about this because it's such an issue. 3 out of 4 times people go in the hospital, you think you go there to get better, 3 out of 4 times they mess up your medicine. That's a lot, right? And I know there's stories in this room of hospital screw-ups. And the reason is because there are lots of patients for each nurse. There are certain times they're used to giving medicine, but when you have Parkinson, you can't wait on someone else's schedule sometimes. Your medicine wears off and you need it on certain times. So the National Parkinson Foundation actually made a toolkit, and they were able to give it out for free based on donations that came in, that has in there important information that you give to the doctors and the nurses that says, I have Parkinson's, I need my medicine on time, every time, don't stop my medicine suddenly. They're actually available in the back of the room. If anyone doesn't have one, you need one. They're free. And they even have these tear-off papers that say, do not give me these medicines. There's a list of medicines that'll make you worse when you have Parkinson's. Your symptoms will be aggravated by those medicines. And there's a list of this is what you can give me instead. So it's really helpful, especially because you think that all the doctors know about Parkinson's and know what not to give you. That's not the case. And we've learned that by lots of research. So those papers are free. They don't listen if you say, I don't think I need this medicine. Well, maybe they will listen to you, but often they won't. But if you say the National Parkinson Foundation says, I'm not supposed to get this medicine, they may actually hopefully pay a little more attention. In there's also a bracelet, if you choose to wear it, that says I have Parkinson and some other useful things. The bottom line is you go in the hospital, your medicine should not be stopped suddenly. Okay. The next question is, when do we add levodopa? There are definitely times that levodopa is the first medicine that should be used for a person, but sometimes we add it later and try other things. We consider age and how long we think a person's going to be living with Parkinson's when we think about when and what to start. We think about how bad are the symptoms. If they're very subtle, like the first person we talked about, maybe a milder medicine is appropriate. If the symptoms are very disabling, maybe we don't have time to mess around with milder things and we need to go straight to something that we know has more potency. We also look at what side effects a person has had and how their symptoms are changing over time, and again, cost considerations. Levodopa comes in 3 formulations and 1 is being looked at in trials. The first formulation is Sinemet, carbidopa-levodopa, and I already talked earlier, if people were here from the beginning, that the levodopa is the good stuff that your body turns into dopamine, and the carbidopa is along for the ride so you don't get an upset stomach. It prevents an enzyme that makes it into dopamine in your belly so that it can get all the way to your brain where you want the dopamine. Some people with nausea may need a little extra carbidopa, which can come in a different pill, to supplement that and prevent the nausea. Somebody asked me about that in the break. Parcopa is a form of Sinemet that melts in your mouth. So it's the same stuff, it's not any better, it's not any quicker, but it melts in your mouth. So if you have a hard time swallowing pills, that can be helpful because you just put it there, it melts, and you only swallow the saliva. You can actually chew Sinemet too. That's another pointer that for some people can be helpful. In fact, sometimes that makes it kick in a little quicker, but it is safe to do that. There's another formulation called Stalevo, which is carbidopa-levodopa with another medicine called entacapone added in. And I'll tell you about that in just a second, but that's a medicine that may extend the duration of benefit or enhance the benefit from Sinemet by inhibiting the way the body breaks down dopamine so that it can be a little bit more effective. And Stalevo comes in a lot of different milligrams. Right now in clinical trials, we're looking at a pump that keeps, you know, a lot of times we've discussed the problems with the ups and downs. There is a new thing being looked at. It's only being looked at new here. It's already been in use in Europe for a long time. It's known to be effective. but it's a continuous duodenal infusion, meaning it's a little pump that keeps a steady amount of dopamine coming in all the time. It does involve a surgical procedure to have a little tube put in, and it does involve carrying around that little pump with the medicine, but it's a very interesting thing that's being studied in clinical trials right now. So this is a picture of kind of what people might experience over time with Parkinson's, and I'll explain it, and it's okay if you can't see it from the back. In early Parkinson's, we talk about a therapeutic window, meaning the difference between too little and too much medicine. How much you need a certain amount or you're not going to get any benefit, but too much you get side effects. So we want to be in that perfect zone between too little and too much. That's what we call the therapeutic window. And in early Parkinson's, that range is kind of wide. And you might be able to take just a few doses in a day and keep that benefit all day long without hitting side effects and without wearing off. The longer people have Parkinson's, that margin gets narrower and narrower, where it's a lot easier to get side effects and it's a lot easier for it to wear off. So there can be ups and downs or fluctuations. So if you can see this first graph, the medicine lasts a long time and it doesn't hit the side effects for many people. The longer you have it, it doesn't tend to last as long. It's not because the medicine stops working in as much as Parkinson's keeps changing in the brain. And those cells that we looked at in that black area, the substantia nigra and in other places in the brain, are getting more impact from Parkinson's. And so the neurons that are left are different from what was left 10 years ago. It changes over time, and the same amount of medicine has a different impact. Okay, the last class of medicine I want to mention are called catechol O-methyltransferase inhibitors, or COMT inhibitors. These medications include entacapone and tolcapone. Tolcapone is a medicine that you probably haven't heard of because it's very rarely used anymore. It's a medication that was kind of taken out of practice due to causing a serious liver disease, fulminant hepatic failure. But it actually was a pretty good medicine if it didn't kill your liver. So it actually is allowed to be used, but it has to be monitored very closely, and it's almost never used very much anymore. The other one, Comtan, is very commonly used. And this medicine, when I showed you that picture of this is where the dopamine goes and it sticks to these receptors, and these medicines help it not get chewed up and removed. This is one of the ones that helps it not get chewed up and removed. It inhibits an enzyme that metabolizes dopamine, allowing it to stay active. So this medicine can make your urine orange. If that were to happen, you shouldn't panic. It's okay. It's just a side effect. It's not a dangerous thing. It's a cosmetic sort of thing. It can cause diarrhea. And any Parkinson medicine could aggravate dyskinesia, that involuntary movement, and it can cause hallucinations or contribute to that. So basically, sometimes it's trial and error to see what's going to work for each individual. So what happens when you experience fluctuations? When you take your pill, it works, and then it wears off, and you're waiting for the next one. Sometimes it means you need medicine more often, more doses in a day, because it just won't last as long. Sometimes you have to actually adjust the timing of your medicine relative to your meals. We talked earlier about most people could take their medicine with food and do just fine, but for some people that can affect how much you absorb to make it less active, and that taking it on an empty stomach actually may give you a little bit more benefit. And just an interesting thing to throw out that has recently been looked at, not an important thing for many people, but it is an interesting thing that came out in a recent study. There's this bacteria called Helicobacter pylori. It's this bug that lives in lots of us. Probably more than half of us have it in our belly somewhere, and it usually doesn't cause us problems. But this interesting research found that for some people, when they treated them with an antibiotic for that, they started absorbing their levodopa better. It's tricky because usually when you have that, it just sort of hangs out in you and doesn't do anything bad, but there's been a little bit of research, so you might hear more about that. I mention it because I had a feeling someone might ask about it. Okay, those are the medicines. What do we do? When do we think about surgical options for Parkinson's? So surgical options for Parkinson's started out being things like burning a hole in the area of the brain called the basal ganglia, these deep areas that we know Parkinson's, that are involved with Parkinson's. that was called ablation, making a lesion that actually interrupts the abnormal pathways. But what would happen is, if you made that just a little to the side or a little in the wrong location, people could have serious problems like paralysis or numbness, and also over time it became less effective. So now we've evolved into deep brain stimulator surgery, which is implanting an electrode, and I'll show you pictures, and using electrical pulses to stimulate that area of the brain. So I'll tell you a little bit about that, but first of all, when would I even think about a surgical option? If you're doing great on pills, you probably wouldn't think about a surgical option. We maximize medical therapy first before we move on to surgical therapies. We think about surgical therapies only for people who have idiopathic Parkinson's disease, not those mimics that I told you about and that many people had questions about. This is not a therapeutic thing that's helpful for people with multiple system atrophy and PSP that we discussed. It's helpful for people with Parkinson's disease that do benefit from their medicine. So if medicine never worked, it's unlikely that DBS would work. People who do benefit from their medicine, but they develop those dyskinesias, those involuntary movements. It can help suppress those involuntary movements. Or people who have ups and downs where it wears off and they can't take it often enough, or it's becoming difficult to keep between the ups and the downs. We usually recommend screening for severe dementia, and we don't recommend the surgery in people with severe dementia because people who go through any surgery, including brain surgery, could worsen after surgery, and so we don't want to take someone who already has severe cognitive problems. Also, people need to be able to discuss and participate after the surgery and how well they're doing. People have to be able to come in and say, yeah, I think that setting helped me, or that setting didn't help me. We also like to know that any psychiatric disease is either mild or treated. So it's not recommended if someone has very severe depression and they're having suicidal thoughts to go through something big like a surgery until that's stabilized. Okay, this is just a picture, a schematic or cartoon of the lead implanted into the basal ganglia with a wire that's under the skin that tracks down into this battery in the chest called a pulse generator. This is a picture of a lady who has a head frame attached that's used during the operation so the surgeon knows where to put that lead. The lead is like almost like a wire, very, very thin wire. The hole that's made is like the size of maybe a quarter. A little hole gets made, and the person is actually awake during the operation most of the time. The brain itself doesn't mind when you touch it. You don't feel it. But your skin and your bones and those things feel, so they have to be numbed very thoroughly. And this frame is attached so the surgeon can map the exact coordinates of where he needs to go. Well, how does he know? He gets an MRI and a CT, and the computer makes a map that links to that frame and tells the surgeon exactly where to implant the lead. This is in the operation. You can see on the bottom, this is how thin the lead is that's in the brain. It's very small. This is some of the imaging technology that gets used. And this is the surgeon in the operating room, and this is a neurologist who's testing the patient and saying, please tap, hold out your arm, and actually interacting during the surgery. When certain actions are done, those cells in the brain fire differently, and it helps the person can hear. There's something called microelectrode recording. That actual wire can transmit the electrical activity happening and turn it into noise and waveforms that a neurologist or a surgeon can interpret to know they're in the right area of the brain. Very technical stuff. The important part is that it's very important it gets put in the perfect spot. Just one little millimeter, one little tack on a ruler in the wrong location can be a problem. This is another cartoon showing the placement. And this is an imaging study that just shows what it looks like once it's put in. That's when surgery is used, when medicine works but there are too many ups and downs or the dyskinesia becomes problematic. So let's not forget, this isn't all about tremor and walking. We talked about all that non-motor stuff, and we spent a whole lot of time earlier today talking about all the non-motor stuff. Let's not forget that a lot of those things are also treatable. And just as two examples, we talked about cognitive impairment. There are medicines that may help a little bit, activities that can help. We talked about depression. It can be treated. Anxiety can be treated. Apathy is challenging, but certain things can be done to try to counteract that problem. Hallucinations can be treated, and on, this whole list. So you have to talk with your healthcare provider about these things. As an example, we talked about the problem that when you get up too quick, you feel woozy or dizzy. We call that problem orthostatic hypotension, with changes in position, blood pressure drops that cause dizziness or lightheadedness. The valves on the veins may not work as well to circulate the blood quickly when you stand, and your brain is smart. Your brain says, whoa, if I'm not getting enough blood, I'm going to fall down. That's what passing out does. Then the blood can get to the brain more easily. So that problem can be managed. Sometimes it means getting rid of medicines that are making you have that problem. Oftentimes, probably 90% of the time, it could mean not consuming enough water and fluids. If you're dehydrated, you're more prone to this problem. Sometimes we add a little salt into the diet and it helps this problem with the blood pressure drops. And if none of that works, we've got several medicines that can be helpful. Another example are hallucinations or psychosis. When we talk about psychosis, what we're talking about is a disturbance in a person's perception so that they feel reality looks different than what it really is. An example would be feeling suspicious that someone that loves you is actually misleading you. So distrust or paranoia. Another example would be visual hallucinations. Thinking you saw something go by that wasn't really there, or thinking you see children or animals. Most of the time they're not stressful, and oftentimes people may know it's not real, but sometimes they actually do become disruptive and make an individual feel scared or distressed. And in that case, we can sometimes get rid of medicine that's causing the problem. Sometimes we have to change the therapy, and sometimes we have to add medicine to counteract it. There are times where you just can't lower your medicine because you gotta move, you gotta walk. And if you can't lower your medicine, we can add something to reduce the hallucinations or those side effects. Two examples of these medicines are quetiapine, which is a medicine that can counteract those side effects, and another one is called clozapine. Without getting in a lot of detail, clozapine is an older one that works great, but it can cause a very serious side effect of suppressing blood counts. It's so important of a side effect that you can only be on that one if you get involved in a registry and have a blood test every single week until you've been on it long enough that it gets spaced out gradually over time. But the quetiapine can be very simple and can counteract that for many people. So that's medicine. Well, what else is there? Is it all pills? No, it's not all pills. There are things besides pills. This is our team at the University of Florida, but there are teams in other places. Physical therapists, speech therapists, occupational therapists, adjunctive healthcare providers can be critical to do what medicine can't do. Speech therapy can be useful for problems with slurring of speech and lowering of the volume, and also for looking into swallow. In general, we say Parkinson's doesn't kill you, but it changes the way you do stuff. There are two times that Parkinson's can be life-threatening in particular, and that can be if you're falling or if you're choking. And Parkinson's can affect the way people swallow, which makes them at risk of food going down their windpipe instead of their food pipe, the trachea instead of the esophagus. And so that's called aspiration, when food goes down the windpipe. Speech therapists can do swallow tests to tell if that's happening, and sometimes they can make recommendations of things that you do differently to lower the risk of that happening. Physical therapists are especially helpful for the walking and the freezing of gait, but it's actually important that if you have the luxury of having a physical therapist with experience in Parkinson's disease, it's actually quite, there's an advantage over someone who doesn't see a lot of it. Some centers have a model of seeing one of a physical therapist that has a lot of experience in Parkinson's and having them tell the one in your area what to do with you so you don't have to travel frequently. An occupational therapist can help with things of daily life, like how the heck do I get my socks on? How do I button my buttons? What do I do if I shake when I want to eat? And sometimes they know a lot of tricks, like changing the kind of cutlery you use or certain tools that they have that make things easier to do. Both physical and occupational therapists can help with someone came and asked me on the break, I have problems rolling over in bed, how do I deal with that? And they can teach you some tricks. A home exercise plan is very important. Sometimes you know what to do, but oftentimes you can benefit from someone telling you what would be helpful. For some people, there might come a time where assistive devices are helpful, meaning a cane or a walker or something that helps reduce the fall risk and lets you be as mobile as you want to be. And those people specialize in what's the best one. Simple things at home can be helpful, like night lights. You're more likely to fall if you can't see where you're going. If your coordination is not as quick or as fast, you rely more on your vision and your sensation, and so having a little nightlight can be helpful. Get rid of stuff you can trip on. Get rid of throw rugs. Try not to leave stuff around the floor, clothes, and so forth that you can trip on. And some people may benefit from bars. And these kinds of therapists even can come into the home and look around and tell you what would be helpful if you need that. Somebody asked me, what kind of exercise should I do and how much? So I threw this in ahead of time because I don't even necessarily care what you do as long as you do it. So get active, find what you enjoy, if it's swimming, if it's dancing, if it's bicycling, whatever you can do safely and regularly, that's what I recommend. Some people would have a hard time safely getting on and off of a regular bicycle, but a stationary bicycle can be quite safe with maybe a challenge to get on and off for some individuals, but less risk of falling off of it. So if you need ideas, a lot of times a physical therapist can help with that too. So finally, we've talked about everything today, surgical and non-surgical and medical and non-medical treatments. Just a preview of some of the things being looked at. I talked to you a little bit about that interesting little thing about caffeine that I thought was fun and how it turned into something interesting with this new class of medicines. There's research going on into these adenosine 2A receptor antagonists. There's a new formulation of levodopa coming out, or at least being studied, which is a new slow release form that has little beads inside of it that when it goes in your belly, they dissolve at different times so that it can kick in fast, because a lot of people with the slow release form find that it doesn't kick in fast enough because it trickles out. This one has some that come right away and some that come later and later, so that may be an advantage. I told you a little bit about the duodenal infusion, or duodopa. And there are studies looking at when should DBS be done. Is it okay to do it sooner? There's been a study that shows that it's okay to use in young onset Parkinson's. At first it wasn't clear, well, what if someone had Parkinson's from their 30s? Can you do DBS? And yes, it can help those people too. But we still don't know when's the perfect time. So those are things that are being looked at. And I'd be happy to answer questions again. We have a nice chunk of time again, about 15 minutes. Okay. Sinemet, immediate release versus slow release. What is the difference in effectiveness? How long do you expect each to last between doses? The first question I can answer. The second one is not a number that I can tell you. How are they different? The slow release formulation is just that. It trickles out in a slower way rather than taking effect right away and wearing off. The advantage that some might expect of a slow release would be less doses in a day or lasting longer, but unfortunately, it's more variable in how much you absorb each time because of the way it sits. It's more influenced by what you ate that day. For most people, it will feel less potent than an equivalent milligrams of immediate release. So if you're used to 100 milligrams of immediate release and you went to the same amount of slow release, it will probably feel less helpful because you won't reach the same peak because it kind of trickles out. For some people, it can be useful if they can't tolerate regular Sinemet because they get side effects when it's at its peak, because it doesn't get to quite the same peak. But interestingly, in studies, it turned out people still need multiple doses in a day. There's not a set number of hours. This is how many hours the one will last, and this is how many the other. It's different for each person and your own metabolism. Earlier in Parkinson's, they tend to last longer because you're still making enough of your own dopamine that you're less dependent on each milligram that you get from a pill. The longer you have it, you may have less of your own and be more reliant on the medicine, and that's where people can notice that it doesn't seem to last quite as long. Okay. Okay, this is a question about carbidopa or Lodicin. This person took a medicine called Stalevo, which is carbidopa, levodopa, and tacopone combination pill, and had nausea. And the doctor prescribed Lodicin, which is just a little extra carbidopa. There's some people that the amount of carbidopa in a Sinemet pill just isn't quite enough and they need extra carbidopa. It is available in a pill by itself called Lodicin, and the drugstore said there was no such medicine. They're wrong. I'm sorry that you had that experience. I would encourage you to either look at a different drugstore or have your doctor communicate, because it might be that there was sort of a new or inexperienced person. I'm sorry you had that experience, because of course that's routinely available. Now your drugstore probably won't have it on their shelf. They'll probably have to get it for you because it's not used as commonly that they just keep it stocked. Okay, what are the pros and cons of increasing your medicine if there's an event you want to attend? And that's a really good question. And I would encourage you, anything that you sort of perceive of yourself that you think, you know, I think I know that I may need a little more in certain circumstances, I would encourage you to talk it over with your doctor or healthcare provider, because you might be right. But it's much better to have that sort of supervised rather than just think you can sort of sort it out on your own. It's actually important to get some advice and guidance. But yes, there are certain times that under your doctor's discretion and your own, it might be appropriate to say that most days if I take one Cinemet 3 times a day, I'm good, but when I go to church, there are people around and I just shake more, or when I go out with my friends once a week, I'm very active and I just feel like it doesn't do quite enough. It might be appropriate that there are certain circumstances that you would say, yes, on those days or those circumstances, you need an extra half a pill. Try not to do it on your own and just discuss it with your doc, but that can be helpful. The pros are that on most days you may not need that amount of medicine, so you're really taking the amount you need, and the con would be, you know, it can be unpredictable if you're doing things different one day to the next. It can be harder to know what's the next step you need with your medicine. So I definitely say talk over anything like that with your doc. I think that this question is asking about if speech could change worse after DBS. I think that's the question. And it's interesting because DBS can be just a miracle worker for many people, deep brain stimulator surgery. But like any great treatment, there are people who could have side effects. And one side effect can be changes in the speech in a negative way, or changes in the gait in a negative way, or changes in cognition in a negative way. So the reason is there are some pathways that are called corticobulbar fibers, and they're these pathways that control all the movements and coordinations that happen to talk. And they're very close to the areas that are getting operated on, and they can be affected. Sometimes changing the stimulator settings can get rid of that side effect. Once the brain surgery is done, there might be an effect just of putting the wire in. But actually, once it gets turned on with the electrical activity, that can be programmed hundreds of different ways. And you have to go in repeatedly and have the settings changed until you find just the right setting. Well, there may be a setting that is very good for walking, but it makes speech worse because the pulses of the electricity kind of get carried over into the areas that you need to do the speech. Changing those settings might be able to change the electrical current in a way that avoids that. So they may be able to be overcome, but there could be times where it couldn't. Can my general practitioner who specializes in geriatrics monitor my Parkinson's? What I said earlier was the most important thing is you're taking care of somebody who has experience, comfort, and familiarity with Parkinson's and understands sort of the nuances of it. And I'm sure that there's a geriatrician who has great experience. They take care of people in they specialize in the age range of individuals who are most prone to Parkinson's. So they may have great experience and expertise. There's variability in neurologists and how good they are, one to the next, and there would be variability in primary care providers. So that's the kind of thing that it really just depends on that doctor. This question is about a book that somebody read called Minding Your Mitochondria about, it looks like it says it's about MS, if I understand this. And they're asking if there's a mention of mitochondria in Parkinson's. And the answer is yes. The mitochondria are these organelles under a microscope inside of us that are involved for energy production. Not just energy like I feel energetic, but the energy required to run stuff in the body. And yes, there is some evidence that the mitochondria may have a role in Parkinson's. Some problems with clearing defective mitochondria have been detected in people with Parkinson's. And it's something that is an evolving area.